CEN written exams in English. Question 1. A patient presents with a near-drowning event. The CEN should be aware of which complication? Option A, aspiration pneumonia. Option B, pulmonary edema. Option C, hypoxia. Option D, all of the above. The correct answer is option D, all of the above. Near drowning can lead to aspiration pneumonia, pulmonary edema, and severe hypoxia, which may progress to ARDS. The priority is airway management, oxygen, and treating any underlying causes, e.g., cervical spine injury. The patient should be monitored for respiratory distress, electrolyte abnormalities, and neurologic injury. All of these complications are possible and require monitoring. Question 2. A patient presents with preeclampsia, headache, visual changes, epigastric pain, and elevated liver enzymes and platelets. This patient is at risk for Option A, eclampsia. Option B, HELLP syndrome. Option C, placental abruption. Option D, preterm labor. The correct answer is option B, HELLP syndrome. HELLP syndrome is a severe form of preeclampsia characterized by hemolysis, elevated liver enzymes, and low platelets. It presents with epigastric pain, nausea, headache, and visual changes. HELLP requires immediate delivery to prevent maternal and fetal morbidity/mortality. Magnesium sulfate is used to prevent eclampsia, and delivery is indicated. Question 3. A patient with renal failure presents with fluid overload, dyspnea, and hypertension. Which intervention is a priority? Option A, hemodialysis. Option B, 4-furosemide. Option C, 4-nitroglycerin. Option D, all of the above. The correct answer is option D, all of the above. The management of renal failure with fluid overload includes 4-furosemide to remove fluid, nitroglycerin or other vasodilators to reduce afterload, and hemodialysis if the patient is not responsive to these measures. Dialysis may be needed for severe hyperkalemia, refractory fluid overload, or uremic symptoms. Acidosis may also require bicarbonate. Question 4. A patient presents with severe eye pain, headache, nausea, vomiting, and a cloudy cornea. Which diagnosis is most likely? Option A, central retinal artery occlusion. Option B, acute angle closure glaucoma. Option C, retinal detachment. Option D, corneal abrasion. The correct answer is option B, acute angle closure glaucoma. Acute angle closure glaucoma presents with severe eye pain, headache, nausea, vomiting, a red eye, a cloudy cornea, and a fixed, mid-dilated pupil. It is an emergency requiring immediate reduction of IOP with topical beta blockers, alpha agonists, carbonic anhydrase inhibitors, and hyperosmotic agents. Miotic agents, pilocarpine, are used after the acute attack is controlled. Question 5. A patient with an orbital fracture presents with diplopia, enophthalmos, and subconjunctival hemorrhage. Which complication should the CEN suspect? Option A, optic nerve damage. Option B, globe rupture. Option C, entrapment of extraocular muscles. Option D, all of the above. The correct answer is option D, all of the above. Orbital fractures can cause entrapment of extraocular muscles, leading to diplopia and restricted eye movement, enophthalmos, and possible optic nerve damage or globe rupture. A thorough ophthalmological examination is needed. CT scan of the orbit is the diagnostic test. Surgical intervention may be needed for entrapment and enophthalmos. Question 6. A patient presents with a bowel obstruction, nausea, vomiting, abdominal distension, and obstipation. Which imaging study is preferred? Option A, abdominal X-ray. Option B, CT scan with oral contrast. Option C, ultrasound. Option D, MRI. The correct answer is option B, CT scan with oral contrast. CT with oral and 4 contrast is the preferred imaging for suspected bowel obstruction, as it can identify the location, cause, and complications of obstruction. Abdominal X-ray may show air fluid levels but lacks specificity. Ultrasound and MRI are less sensitive. Management includes NPO status, NG tube placement, for fluids, and surgical consultation. Question 7. A patient with hypothermia, core temperature 30 degrees Celsius, is unresponsive. The CEN should: Option A. Rewarm the patient with active external rewarming, e.g., warm blankets. Option B. Rewarm with active internal rewarming, e.g., warm for fluids, warm humidified oxygen. Option C. Administer 4 antibiotics. Option D. Defibrillate for VF. The correct answer is option B. Rewarm with active internal rewarming, e.g., warm for fluids, warm humidified oxygen. Hypothermic patients with temperatures below 32 degrees Celsius are at risk for cardiac arrest. Active internal rewarming is the priority. External rewarming can cause afterdrop or rewarming shock, peripheral vasodilation causing hypotension. Defibrillation may be attempted for VF, but if the patient is severely hypothermic, the heart may not respond until rewarming is initiated. Management is supportive. Question 8. A patient presents with sudden onset of severe, sharp, lower abdominal pain radiating to the flank, nausea, and hematuria. Which diagnosis is most likely? Option A. Appendicitis. Option B. Renal calculi. Option C. Ovarian torsion. Option D. Diverticulitis. The correct answer is option B. Renal calculi. Renal calculi, kidney stones, present with sudden, severe flank pain, renal colic, radiating to the groin, nausea, vomiting, and hematuria. CT scan without contrast is the diagnostic test of choice. Pain control, for opioids or NSAIDs, and fluids are the mainstays of treatment. Ovarian torsion presents with adnexal pain and should be considered in female patients. Question 9. Which of the following is the most effective approach for de-escalating an agitated patient? Option A. Use a firm, loud voice to establish authority. Option B. Maintain a calm, non-threatening tone and provide personal space. Option C. Immediately call security for assistance. Option D. Restrain the patient. The correct answer is option B. Maintain a calm, non-threatening tone and provide personal space. De-escalation is a key skill for emergency nurses. It involves using a calm, non-threatening tone, maintaining personal space, acknowledging the patient's feelings, and allowing them to express themselves. Firm, loud voices can escalate agitation. Security may be needed if de-escalation fails, but it should not be the first approach. Restraints are a last resort. Question 10. A patient with mania is disruptive and not responding to verbal redirection. The patient is placed in 4-point restraints. The CEN should monitor the patient every. Option A. 30 minutes for circulation, nutrition, elimination, and mental status. Option B. 60 minutes. Option C. 15 minutes. Option D. As needed. The correct answer is option C. 15 minutes. Restrained patients require frequent monitoring to ensure safety. In ED settings, restrained patients should be monitored every 15 minutes for circulation, respirations, nutrition, elimination, and mental status. Restraints should be used only for patient or staff safety when less restrictive measures have failed. Restraint orders require a physician's order and are time-limited. Question 11. A patient presents with a foreign body sensation in the eye, tearing, and photophobia. The CEN should: Option A. Use a slit lamp to examine the eye. Option B. Perform fluorescein staining and a slit lamp exam. Option C. Irrigate the eye. Option D. All of the above. The correct answer is option D. All of the above. A corneal foreign body or abrasion requires a thorough examination under a slit lamp with fluorescein staining to identify the location and extent of the injury. Irrigation may be needed to remove loose foreign bodies. The CEN should identify and remove the foreign body if visible or refer to ophthalmology for removal. Antibiotics are often prescribed. Question 12. A patient with heart failure presents with severe dyspnea, pink frothy sputum, and rales auscultated halfway up the lung fields. The CEN should anticipate which intervention? Option A for normal saline bolus. Option B for furosemide and nitroglycerin. Option C for epinephrine. Option D immediate intubation. The correct answer is option B. For furosemide and nitroglycerin. This patient is in acute decompensated heart failure with pulmonary edema. Management includes diuresis, furosemide, and afterload reduction, nitroglycerin, to reduce preload and afterload. Oxygen and non-invasive positive pressure ventilation, BiPAP/CPAP, may also be used. Normal saline would worsen volume overload. Intubation may be needed if the patient fails non-invasive measures. Question 13. A patient with a known abdominal aortic aneurysm, AAA, presents with acute, severe back and abdominal pain. The CEN should: Option A obtain a CT with contrast. Option B prepare for emergency surgery. Option C administer 4 fluids for hypotension. Option D. All of the above. The correct answer is option D. All of the above. This patient has a ruptured AAA until proven otherwise. The priority is surgical consultation and preparation for emergency repair. CT may be done to confirm but should not delay surgery. 4 fluids should be given cautiously, permissive hypotension, to avoid increasing bleeding. This is a time-critical surgical emergency. Question 14. A patient with sepsis has a MAP of 55 mmHg despite fluid resuscitation. The CEN should anticipate which vasopressor? Option A dopamine. Option B norepinephrine. Option C phenylephrine. Option D epinephrine. The correct answer is option B. Norepinephrine. Norepinephrine is the first-line vasopressor for septic shock. It increases MAP through vasoconstriction and is preferred over dopamine due to a better safety profile. The sepsis protocol recommends early broad-spectrum antibiotics, within 1 hour, 30 ml/kg crystalloid, and vasopressors for fluid refractory shock. MAP target is 65 mmHg. Question 15. A patient's ECG shows a heart rate of 40 bpm with wide QRS complexes and no association between P waves and QRS complexes. This rhythm is: Option A sinus bradycardia. Option B atrial fibrillation. Option C third degree AV block. Option D ventricular escape rhythm. The correct answer is option C. Third degree AV block. Third degree, complete, AV block is characterized by complete dissociation between atrial and ventricular activity. The atrial rate is usually faster, P waves, than the ventricular rate, wide QRS escape rhythm. This is unstable and may require transcutaneous pacing or atropine, though atropine is less effective for infranodal blocks. Question 16. A patient with capacity refuses life-saving treatment and wants to leave against medical advice, AMA. The CEN should: Option A allow the patient to leave after documentation and ensuring the patient understands the risks. Option B restrain the patient and start treatment. Option C call the family to persuade the patient. Option D call security. The correct answer is option A. Allow the patient to leave after documentation and ensuring the patient understands the risks. Patients with decision-making capacity have the right to refuse treatment and leave AMA. The CEN should document that the patient was informed of the risks of leaving, and the benefits of treatment, and that they understand. The patient should sign an AMA form. Restraint and treatment without consent are only permissible if the patient is a danger to self or others, e.g., suicidal, psychotic. Question 17. Which sign is most suggestive of a factitious disorder, Munchausen syndrome? Option A. Inconsistencies in the patient's history and symptoms. Option B. A history of multiple hospitalizations. Option C. Unexplained physical findings. Option D. All of the above. The correct answer is option D. All of the above. Factitious disorder is characterized by the patient feigning or inducing symptoms for secondary gain, attention, care. It presents with inconsistencies in history, multiple hospitalizations, and unexplained physical findings. Unlike malingering, there is no external gain. Careful history, documentation, and consultation with psychiatry are recommended. Question 18. A patient who is depressed and suicidal is admitted to the ED. The CEN should. Option A. Ask the patient if they have a plan to harm themselves. Option B. Avoid asking about suicide to prevent giving the patient ideas. Option C. Ask the patient only about feelings of hopelessness. Option D. Ask the patient about their mood. The correct answer is option A. Ask the patient if they have a plan to harm themselves. Asking about suicidal ideation and a specific plan is essential for risk assessment. It does not give the patient ideas but helps the healthcare team determine the level of risk and implement appropriate safety measures. Direct, non-judgmental questioning is recommended. Evaluation of intent, plan, and means is critical in assessing suicide risk. Question 19. A patient with alcohol withdrawal presents with tremors, hypertension, tachycardia, and diaphoresis. The CEN should anticipate. Option A. Benzodiazepines, lorazepam, chlordiazepoxide. Option B. Antipsychotics. Option C. Beta blockers. Option D. 4 fluids only. The correct answer is option A. Benzodiazepines, lorazepam, chlordiazepoxide. Benzodiazepines are the first-line treatment for alcohol withdrawal, reducing the risk of seizures and delirium tremens, DTs. They work by augmenting GABA, thus preventing sympathetic overdrive. Chlordiazepoxide, Librium, and lorazepam, Ativan, are commonly used. DTs are a medical emergency requiring ICU-level care. Antipsychotics and beta blockers are adjuncts or alternatives but not first-line. Question 20. A patient with hyperkalemia has a potassium level of 6.8 milliequivalent/L and peak T waves on ECG. Which intervention should the CEN anticipate? Option A. Sodium bicarbonate. Option B. Calcium gluconate. Option C. Insulin with dextrose. Option D. All of the above. The correct answer is option D. All of the above. Hyperkalemia management includes membrane stabilization, calcium gluconate, to protect the heart, shifting potassium into cells, insulin with dextrose, sodium bicarbonate, beta agonists, and removing potassium, K-oxalate, dialysis. Calcium gluconate is given first if there are ECG changes, peak T waves, widening QRS. Insulin with dextrose and sodium bicarbonate shift potassium into cells. K-oxalate or dialysis removes potassium. ECG changes indicate a life-threatening emergency. Question 21. Which medication is used to manage postpartum hemorrhage? Option A. Oxytocin. Option B. Misoprostol. Option C. Tranexamic acid. Option D. All of the above. The correct answer is option D. All of the above. Postpartum hemorrhage, PPH, is managed with uterotonics. Oxytocin is the first-line agent, misoprostol and methylergonavine are second-line or adjunctive agents. Tranexamic acid is a recent addition to the management of PPH, reducing bleeding and mortality. Uterine massage, 4 fluids, and blood products are also indicated. Question 22. A patient presents with a fractured ankle, severe pain, and inability to bear weight. Which intervention is appropriate? Option A. Apply a splint and elevate the leg. Option B. Apply a cast and discharge the patient. Option C. Administer 4 antibiotics. Option D. Apply a tourniquet. The correct answer is option A. Apply a splint and elevate the leg. An uncomplicated ankle fracture should be splinted, not casted, to allow for swelling, and the leg should be elevated to reduce swelling. The patient should be evaluated for a fracture and the neurovascular status documented. Casting is not appropriate until swelling has resolved. Antibiotics are not indicated for closed fractures. Question 23. A patient with a dog bite wound presents with redness, swelling, and purulent drainage. The CEN should: Option A. Irrigate the wound and prescribe antibiotics. Option B. Culture the wound and start empirical antibiotics. Option C. Close the wound primarily. Option D. Apply a pressure dressing. The correct answer is option B. Culture the wound and start empirical antibiotics. Infected wounds, cellulitis, abscess, require cultures and antibiotics. Dog bites can be infected with Pasteurella, Capnocytophaga, and other organisms. Empirical antibiotics, amoxicillin clavulinate, are often started. The wound should be opened, drained, irrigated, and debrided. Primary closure is generally not recommended for infected wounds, they are left open for drainage. Question 24. Which finding is classic for cardiac tamponade? Option A. Widened pulse pressure. Option B. Beck's triad, hypotension, muffled heart sounds, JVD. Option C. Kussmaul's sign. Option D. Pericardial friction rub. The correct answer is option B. Beck's triad, hypotension, muffled heart sounds, JVD. Beck's triad is the classic presentation of cardiac tamponade, hypotension, from decreased cardiac output, muffled heart sounds, fluid in pericardial sac, and jugular venous distension, impaired right heart filling. Other findings include pulsus paradoxus and electrical alternans on ECG. Emergent treatment is pericardiocentesis. Pericardial friction rub suggests pericarditis. Question 25. A patient with COPD and a history of hypercapnia is being treated with oxygen. The CEN should aim for a target SpO2 of: Option A 100%. Option B 94 to 98%. Option C 88 to 92%. Option D 85 to 88%. The correct answer is option C. 88 to 92%. For patients with COPD and chronic hypercapnia, CO2 retention, the target SpO2 is 88 to 92%. This balances adequate oxygenation with avoiding oxygen-induced hypercapnia, depressing the hypoxic drive. The target for healthy patients is 94 to 98%. High oxygen concentrations should be avoided in these patients.